This program is brought to you by Emory University.
All right, good morning. I was riding up in the elevator this morning, and there was a woman, clearly a visitor to the hospital, and I said, "Good morning, how are you?" She says, "Well, I've suffered a tremendous tragedy, but you know, life does go on." And I said, "I'm so sorry for your loss." She said, "Oh, no, I'm talking about the football game." So this morning it is my pleasure to introduce, this is I believe the 7th annual Mark Silverman Memorial Lecture. Many of you of course knew Mark well. Mark was a very close friend, a confidant, a mentor, and certainly one of the finest clinical cardiologists and educators I've ever known. This morning we have the honor of having Diana Silverman, Mark's widow, and Dr. Barry Silverman, who not only practices over at Northside but also volunteers once a week over at Grady in the clinic, which is delightful. Dr. Jokhadar will be saying a few more words about Mark at the beginning of his talk. Mark was not only a consummate cardiologist, but he really was a true Renaissance man with interests that ranged from literature to history, and particularly the history of medicine. And I think, therefore, it is really most fitting that Dr. Jokhadar give this talk, because not only has Dr. Jokhadar at a very young age become a master clinician and educator with the receipt of numerous teaching awards, but he has interests that range far outside of the practice of medicine, and particularly to history and the history of medicine. So I look very much forward to your talk, Maan.
Good morning. Thank you for all showing up after the game last night. So the title of the talk today, in memory of Dr. Silverman, is Observations, Serendipity, and Personality. And this is lessons from the history of medicine. And it's a little bit of stories many of you are already familiar with a slightly different twist. And the twist is focusing on how these things came to pass, how these discoveries occurred. And also a little bit of background about why sometimes really good ideas take a very long time to catch on, and sometimes bad ideas catch on pretty quick. So this is the talk. It was a privilege to know Dr. Silverman. I didn't know him very well, but he was a great clinician, teacher, and fantastic medical historian. Many of the topics that I'll be addressing today have actually been written by Dr. Silverman, and he published a lot on medical history. He was born in Springfield, Ohio, and attended Ohio State. He went to the University of Chicago Medical School, and he did residency at Ohio State. And then one day he was seeing Dr. Hurst speaking at a conference, and he was inspired to be a cardiologist, and he came to Emory to be a cardiologist. Here's Dr. Hurst, and here is Dr. Silverman, and they're studying EKGs in the. I'm not entirely sure I know where this is. I think this is Grady, but I'm not sure where this is. Dr. Silverman spent 2 years in the Air Force, and then he joined the Emory faculty. At a very unique role. He was asked to be a cardiologist in Piedmont. The cardiology fellows at that time rotated at Piedmont Hospital, and he trained many cardiologists who went through there. He's had numerous publications, all the teaching awards, and also of interest, he took a sabbatical in London one year and wrote about the history of English medicine, and as a result was named a fellow of the Royal College of Physicians in London. His proudest achievements may have been all the hard work he did with the nurses, empowering the nurses at Piedmont to take care of the patients and take more of a leadership role. An interesting bit of trivia is Dr. Silverman would give talks at the medical school every year, and he would sometimes dress up as William Harvey, the man who described the cardiac circulation, a contemporary of Shakespeare, and he would march in with chamber music, surprising the medical students, and sometimes he would do this dressed up as William Einthoven, the inventor of the EKG. Here's Dr. Silverman with Dr. Dollar, and here's Gorilla and a TE probe right there. Here's his brother, Dr. Barry Silverman, and here's him with his wife, Ms. Diana Silverman. So Winston Churchill said, the farther back you look, the farther forward you will see. So the learning objectives for today are really recognize some of the factors that influence medical discoveries and how these discoveries are adopted. And really this is mostly medical examples from history. Most of you already know these stories, but there's a little bit of a twist to each of them. So we'll start with herbal remedies. How many of you have been in a situation where a patient said, yeah, I'm taking these herbal remedies, and we dismiss this immediately? Well, this happened to Dr. William Withering, the man who modernized the use of the foxglove and digoxin. Dr. William Withering was a man from Northern England, and he studied medical school at Edinburgh, and he set up shop in Shropshire, and then went to the Birmingham General Hospital where he attended. And one of his first patients he actually became enamored with and married, and she had tremendous botany interest, and that's where he may have gleaned some of his botany knowledge, which would become pretty handy. And then one day he was treating a man with dropsy. Dropsy is an antiquated term for edema or heart failure, and almost universally at that point in time caused by mitral stenosis. So he was treating this man with dropsy. The man clearly wasn't doing well. He told him, why don't you get your affairs in order? I'll see you on the other side. So weeks, months go by, and he sees this patient back. And he runs into them in the marketplace. The guy looks great. And he inquires, what happened? How, you looked so poorly when I last saw you. And he said, well, I was been drinking these teas, these herbal teas. Where did you get these teas from? From the old Mother Hutton from Shropshire. Accounts differ about exactly who she was, but Dr. Withering paid her a visit, and initially she was reluctant to share her magic recipe with him, but after some monies exchanged hands, he got a bag full of various ingredients. And because of his knowledge in botany, he was able to quickly discern that the active ingredient must be the foxglove. The foxglove had been in medical use for a long time, for centuries, but it was limited by its toxicity. So he was interested in how this lady was able to discover that the use of foxglove could be helpful in the treatment of dropsy, heart failure. And so this is the Digitalis purpura plant, the foxglove, named after Leonard Fuchs, the Bavarian scientist. Fuchs glove, you can see it looks like a thimble. You can fit your digit in there, hence the term digitalis. Out in shady areas, colder areas up in the northern part of the U.S. or in England, the deer know better than to eat this. They'll avoid everything except for the foxglove. So he began to study this very meticulously, and he collected 156 cases in the course of 10 years. And then he submitted his paper, The Account of Successful Use of the Foxglove in Some Dropsies and in Pulmonary Consumption. The problem was his confidant, Erasmus Darwin, who was the grandfather of Charles Darwin, who was a very prominent figure at that point in time, and a friend, scooped him. He had heard about the success of foxglove in Dr. Withering's practice, and he actually went ahead and presented some of the information a few months before Dr. Withering did. So here we have a classic case of medical plagiarism, where doctors try to take credit for a discovery that neither of them made. It was old Mother Hutton from Shropshire who actually made this discovery. So think about this next time a patient says, I'm taking these herbs. Unlikely you'll find another digoxin, but something to keep in mind. Here's another story about changing direction, about scientists who had the flexibility in their ability to change completely how they were going about their daily lives and discoveries, and how they weren't tied down by huge grants and being conformist with their current science. And this is the story of how warfarin was discovered. So in the 1920s and 30s, cows in Midwest and Canada were dropping dead from a bleeding disorder. Nobody entirely knew how this happened, except they felt that it has something to do with sweet clover. And so one day, with many cows dropping dead, this you may recall, 1933 was, during the abyss of the Depression, and many farmers were losing their livelihoods with all their cows dying. So a farmer, legend has it that a farmer by the name of Ed Carlson drove through a blizzard. He was completely disgusted with what was going on. He lost all his cows and prize bulls. And he drove through a blizzard to the University of Wisconsin-Madison. And it was a blizzard, no buildings were open, but he found an open building. And he went into this building carrying a bucket of bloody milk, and he plopped it down in the middle of this guy's office. He said, you need to help me figure out why my cows are dying. And surprising thing is Dr. Carl Link actually took it on. And Dr. Carl Link found the missing link. And he completely dropped what he was doing. He spent 6 years of his life focusing on the warfarin question. And before that, he was a carbohydrate scientist. And over time, they figured out what was going on. We all recognize the smell of cut grass. It's a sweet smell. That smell is coumarin. Coumarin, one of my favorite smells. And if you allow certain fungus of the Penicillium family, we'll get to Penicillium here in a little bit. If you allow fungus from the Penicillium family, the coumarin is metabolized to dicumarol, which is an anticoagulant, decades later discovered to interfere with the metabolism of vitamin K. So after several years of trying to figure this out, they finally market it as a rodenticide. Warfarin, Wisconsin Alumni Research Foundation, warfarin. As a rodenticide, they had no inkling that it could be used for medical purposes. And then in 1951, a U.S. Army inductee felt that he needed to take his own life, and so he attempted to take his own life with warfarin, and he took a large amount, but at that time they had figured out that they could reverse it with vitamin K. And around this time, people figured out maybe we can use this for therapeutic reasons, and initial trials were underway, and in 1954, warfarin was finally approved as a medicine. And then another fortuitous event happened in 1955, well, not so fortuitous for the president. President Eisenhower was on a golfing vacation in Denver, visiting his in-laws in September 1955, when he developed a very large myocardial infarction. And a couple days after the infarction, the doctors determined that he may have developed a left ventricle apical aneurysm. For that reason, they wanted to thin his blood. And Dr. Paul Dudley White, who was at the Massachusetts General Hospital and one of the mentors for Dr. Hurst, prescribed this rat poison to the President of the United States, and he was one of the first human recipients of this medication. So I was interested to see how Dr. Link, someone marched into his office with an important question, and he was flexible enough to change direction. It wasn't, I got this grant coming up, can you come back in a few weeks, or, I'll see you later. He actually took on this very important question. Let's talk about the fortuitous observation of penicillin. And we'll talk very briefly about Sir Alexander Fleming, who was a Scottish biologist, and he was working on bacteria at St. Mary's in London. And this man was not a very good communicator, but he was very hardworking. He was a little bit messy, which would actually serve him well. The This argument does not work on my wife, by the way, but but he was a messy guy, not a very good communicator. And one day in 1923, he was working with petri dishes, and he had a bad cold, and a drop of snot fell from his nose onto the petri dish, and he realized that something in his mucus was inhibiting the growth of the bacteria, because there was a halo of lack of growth around the culture of Staphylococcus. And so he discovered lysozyme and published that. And then a few years later, in 1928, he was very messy, left a lot of petri dishes uncovered, went on vacation, left the door to his lab open, and we all know the story. Fungus from a different floor, from an unlikely part of the world, traveled up through the open door and landed on the petri dish. Because of his discovery of lysozyme, he realized that there was something in this fungus lysing, killing this area of bacteria. And he looked at it carefully, and he found that it was Penicillin notatum. The subspecies was later renamed, and he published this. But this remained more of a lab trick for a number of years. Dr. Fleming did not realize that this could have some medicinal properties. By way of interest, penicillin comes from penicillium, which means paintbrush, because these budding bodies look like a paintbrush. Also, similar origin for the word pencil. So here's 1928 is when penicillin was discovered. A decade later, Dr. Flory from Australia and Dr. Chain from Germany recognized that there may be some therapeutic potential to this lab trick, and they wanted to produce more penicillin, but it was very difficult to produce. Penicillium notatum was not a very good mass producer of this agent, and they realized that there was something magical about this fungus and its spores. And around that time, the Battle of London was between Germany and England, and there were constant bombardments from the Germans over London, and they were concerned. They were afraid that they would lose this precious gift that they had been given. So they always had their overcoats, and they always had penicillium spores in their pockets and in the lining of their coats, just in case they had to flee in a hurry, so they could reproduce this. But again, to produce significant amounts was very difficult. So they started looking around at different pharmaceutical companies in England and government agencies, and there was absolutely no interest. So they contacted, in July of 1941, the U.S. Department of Agriculture in Peoria, Illinois. And they traveled there, smuggling spores in their pockets. And when they arrived, they tried to grow the material. They used corn steep liquor as a byproduct of corn and still could not make much. And so they wanted to look for a more potent penicillin. So they searched all over Peoria for rotten vegetables, and finally they came across a rotten cantaloupe in a grocery store. And they peeled off the fungus and proceeded to eat the cantaloupe. And this is the origin of the more potent penicillium that is still the source of, or was the source of most penicillin in the world until recently. And this medication was mass-produced in time for D-Day and saved many lives D-Day and after. And as a result, in 1945, the following year, Dr. Fleming, Dr. Ernst Boris Chain, and Dr. Walter Flory were awarded the Nobel Prize in Medicine and Physiology. And as a result of this fortuitous experiment, we have many other countless agents that are from fungi. Selman-Waxman isolated streptomycin. This was used for tuberculosis. Jean Borel and others from Sandoz discovered cyclosporin from fungus. They were looking for an antifungal agent, and then this is an entirely different story, how they were able to discover that that this fungus they found in Wisconsin also and Norway had some immunosuppressive properties, and this revolutionized transplantation. And obviously, Akira Indo in 1973 found the first statin from another penicillin, Penicillium citronum, from a rice sample collected from a grain shop in Kyoto. So this mucus that fell from Dr. Fleming's nose really had some long-term consequences and benefits. Shifting gears, we'll talk about what happens to an idea when it comes decades before its time. And we'll talk about hand washing and talk about Dr. Ignaz Semmelweis. So Dr. Ignaz Semmelweis was Hungarian physician, and he he trained in Vienna, and he worked at the Allgemeines Krankenhaus der Stadt Wien, or the Vienna General Hospital. And he was a very powerful personality, and he was appointed to be in charge, almost like a chief resident type appointment, 2-year appointment, in charge of the OB wards. And at that point in time, the midwife clinic and the medical student clinic admitted on alternate days. But everybody in the city knew that you wanted to be in the midwife clinic. You did not want to be in the medical student clinic because the mortality was much higher. It was as high as 20%. But the doctors were completely oblivious to this. They were certain in the way they were doing things. They were always covered in blood and never washed their hands after their daily autopsies. And this was a badge of honor to be covered their lab coats covered in blood, that they were hardworking. But everyone in the city knew that you did not want to be admitted to the medical student or doctor's clinic. In fact, some women would actually try to deliver in the street to try to avoid this. All women, in order to get government benefits, had to deliver in the hospital. That's why there was an incentive to deliver in the hospital. So one day, Dr. Semmelweis' mentor, Dr. Jacob Kolechka, was cut by a medical student while performing an autopsy. And he developed a septic shock-like picture related to what we now know as streptococcal infection, which actually looked very similar to the illness all these women were dying from. They were dying from puerperal fever, a streptococcal-borne illness related to the lack of hygiene and slovenly doctors who were taking care of these women who were delivering. And so Dr. Semmelweis had a revolutionary idea. Maybe there's something, particles, on the hands of the doctors and medical students that is causing illness. And germ theory was not yet known. They were still concerning themselves with the balance of humors and miasmas or bad smells. And he figured that because cadavers smell bad, there must be something that is pathologic from these dead women. So he implemented a revolutionary intervention at that time, and had everyone wash their hands in chlorinated lime or bleach powder. And the reason for that was not to clean or to kill the germs. It was to get rid of the bad smell, because that was the thought process at that time. And instantaneously, the mortality went from 20% to 2%. Instantaneously. He was only there for 2 years. And the reason why he was only there for 2 years is because he was Hungarian in Vienna, and it was 2 years later, 1948, there was a Hungarian Revolution, so it was not a good time to be Hungarian in Vienna, and so his position was not renewed, and he had to go. The other thing, he was not the easiest guy to get along with. He was extremely bossy. He was not polite to his underlings, and he was not popular at all. If he saw somebody not scrubbing his hands or washing his hands, he would stand over them, and you wash your hands the way you're supposed to. And that made him extremely unpopular. Also, he had no logical explanation for his dramatic success. And it was mumbo jumbo at that time. Nobody really believed what he was doing. This guy was a little bit off, yeah, we'll tolerate him for a while, but good riddance. Now that he's gone, we'll go back to our old ways. So he goes to Hungary and he implements similar interventions at the hospitals in the Budapest area, and he publishes 15 years later, 16 years later, the etiology of childbed fever and how to prevent it. His ideas were universally dismissed, including by some of the leaders of the field at that time, including Dr. Virchow. Dr. Virchow was the eminent pathologist, one of the eminent doctors of that time, and he thought this idea was crazy. And he was maybe the smartest guy at that point in time, but the fact that he had no allies in the hospitals he worked with, he was not polite to his students, and the elite of the medical profession didn't think his ideas were worth considering. That may be reason why his idea never caught on. Plus, he was Hungarian and may have been considered a sort of a second-class citizen in that period of time. So all these factors may have delayed the implementation of hand washing. And then he started to go a little bit mad, and he became obsessed with the idea that all these women were being killed by their obstetricians. So he sent an open letter to all the doctors in Europe, all the obstetricians in Europe. It was more of a polemic than a letter, an attack. You guys are murderers. You guys are performing malpractice. You guys are nasty people, and that's not how you get your point across. So he could have been a little bit more diplomatic. And then he became so enraged and so unreasonable that his wife actually conspired with others to get him committed to an asylum. And on admission, he was beaten up by some guards and died of an illness that looked a lot like puerperal fever 14 days later. So be diplomatic, I guess, is be diplomatic and be kind to your students. So why was this good idea not accepted? Part of it was his personality, the politics. His idea was rejected by everyone around him, even though they could see the success with their own hands. They just were too proud to believe it, that this a little bit unusual person could come up with such a really good idea. And there was a lack of a good scientific explanation based on current understanding. At that point in time, 1860s, 1870s, medicine was still entrenched in the dogma of Galen and Avicenna and others. The balance of humors. You may recall there are 4 humors, and if there's an imbalance in the humor, you try to bleed if you're having too much blood. If you have too much blood, you're sanguine. If you're too much phlegm, you're phlegmatic. If you're too much black bile, you're melancholy. And if you're too much yellow bile, you're choleric. As a point of trivia, if you look at Stone Mountain Memorial, the last guy to the right is Stonewall Jackson. And Stonewall Jackson in the 1860s, he was actually obviously a Confederate general who believed very strongly in these balance of humors. And before every battle, he would have his arms up to make sure to rebalance his humors. It didn't do him any good when he was shot by friendly fire. But anyway, piece of unrelated trivia. I hope we stay on time. So medicine at that time was a field that was entrenched in dogma. Sound familiar? Let's talk very briefly about germ theory and how that developed into many other branches. I don't do justice by germ theory with one slide in just a few minutes, but let's very briefly go over it. So the Dutch scientist von Leeuwenhoek was very good with lenses, and he invented the microscope. It was a very crude thing, but he was the first to discover microbes. But he didn't think that these microbes were of any pathologic or clinical significance at all. And then Dr. Bassi of Italy discovered that there was a fungus that was killing off many of the silkworms, an illness called muscardine. And he postulated back in the early 1800s that maybe this idea that microorganisms are pathologic can be generalized to everybody. But his ideas were not obviously adopted. It sounds pretty wacky. And then came along Dr. Louis Pasteur and Robert Koch, and they together, though they were very antagonistic to each other, came and refined the germ theory. Louis Pasteur, also another example of changing direction. He was interested in wines and why wines spoiled. And so he discovered that wines have these microorganisms that cause them to spoil. So he invented this method of heating the wine to kill the organisms, and that's something that is called pasteurization, and also applied to milk. He invented the rabies and anthrax vaccine, not immunization. In honor of Dr. Jenner, he wanted to call them vaccine for vaccinia or cowpox. And he founded in 1887, the Pasteur Institute. And then Robert Koch took it one step in addition to that, and he found specific organisms for specific diseases. He found anthrax and he found tuberculosis. And these guys were very antagonistic to each other because in 1870, Germany and Prussia were at war, the Franco-Prussian Wars, and this would make politics get in the way of science, something that we're certainly immune to right now. Sorry. And then also of interest, there was the tuberculin scandal. Tuberculin is a substance that we still use today for our tuberculin skin test, except Dr. Koch, who was a rural physician and became internationally renowned very quickly, determines before doing any clinical trials, before doing any experimentation, that tuberculin was the cure for tuberculosis. At that point in time, 1 in 7 Germans were dying from tuberculosis. And this was very important. So he marketed tuberculin, and he tried to get a lot of money, presumably to pay for his divorce and his much younger wife, but that's an entirely different story that we won't discuss right now. Dr. Lister is the guy who took it the next step, though. Dr. Lister looked at Louis Pasteur and Robert Koch's work and took it the next step. He was a surgeon, and at that point in time, doing surgery was fraught with tremendous risk of infection, and everyone got pus, but was it laudable pus, good pus, or was it the other kinds of pus? So he devised a method of killing bacteria with carbolic acid. And carbolic acid, very smelly phenol that he would spray all over his instruments, his hands. His hands would get meaty red and raw from all the phenol, the carbolic acid that was used. But he used this with tremendous success. What's interesting is that he was completely ignored in Scotland, completely ignored in England. And the people who really took notice were the Franco-Prussians, were the people who were just at war and saw horrific war wounds that kept getting infected. So he would have his auditorium in Edinburgh filled with French and Germans who had just been at war with each other, but agreed to come and see Dr. Lister speak about the concept of antisepsis. And then Germans would take it one step further and create asepsis. Instead of killing the germs in the field, prevent them from getting in there to begin with, and they created the antiseptic technique. So with that in mind, now that we know that that bacteria or microorganisms cause disease, the next step is to try to figure how to target these microbials or these microorganisms and kill them. And along came Dr. Paul Ehrlich. And Dr. Paul Ehrlich is doing early studies on staining bacteria. And he figures that if you can stain a bacteria, maybe a stain or a dye will actually kill it. It was a flawed theory, but this rabbit hole led medicine along a very interesting path. So he came up with salvarsan, which was the very first antimicrobial used for the treatment of syphilis, which was rampant in Europe at that point in time, and he was awarded the Nobel Prize. And as a result of the idea that dyes can have therapeutic effect, an entire industry was born. And IG Farben and its subsidiary Bayer, there was a guy by the name of Gerhard Domach. And Domach was interested in using azo dyes from coal tar and checking for antimicrobial benefit. And after a number of years of working on this, he came along with the very first antibiotic, and that was Prontosil, a sulfa-like antibiotic. And everyone thought that the azole bond was the most important component for antimicrobial. Prontosil, very early in its development, has a lot of side effects. The patient turns bright orange or red when they take it because it's a dye. It's supposed to do that because that's how you kill the germs, is by coloring the germs. So a few interesting tidbits on Prontosil. Soon after discovering it, his daughter, Domach's daughter, gets a septic shock-like illness from an infected arm, presumably from strep. So he experiments on his own daughter, knowing that his daughter is going to get an amputation unless he does something quick. So he gives this compound, this Prontosil medicine, to his own daughter and saves her life. Another tidbit from history is the President of the United States at that time was Franklin Roosevelt. And his son, Franklin Roosevelt Jr., was at the Massachusetts General Hospital with strep pharyngitis and very, very sick, not getting better. So Franklin Roosevelt contacts the German government at that time to send over some Prontosil, and that is done, and Prontosil cures the president's son. Why that's important is only a decade earlier, Calvin Coolidge's son, Calvin Coolidge Jr., died at the age of 16 from a blister while playing tennis. It got infected with strep and he died, and that destroyed Calvin Coolidge, and many think that as a result of that illness and death of his son, that he was no longer an effective president. So these are little tidbits about Prontosil. And then 3 years after Prontosil was discovered, the Pasteur Institute realizes, after some chemical modification, hey, it's not the color at all, it's the sulfa. It's the sulfa that is the active ingredient. And so sulfonamide is the active ingredient, and you don't need to turn the patient's bright orange or bright red to get a therapeutic benefit to kill the bacteria. Other pieces of trivia: Bayer was the main company. After World War I, after World War I, many of the intellectual properties of Bayer were given to the U.S. and Canada, and in 1994, these were repurchased back by the Germans. I could go on and on about this, but this is fun stuff, I think. So, because of the sulfonamides, an entirely new era of medications are developed from these tars, from these chemicals. You have isoniazid and sulfamethoxazole as antimicrobials. Sulfa was found to have some diuretic properties. So Dr. Pitt in New York and others find acetazolamide and then later hydrochlorothiazide and furosemide as a result of the sulfonamides. You know, when we prescribe furosemide to this day in someone who's allergic to sulfa, the first thing that comes up on EMR is this patient's allergic to sulfa, because these are all sulfa medications. The sulfonylureas were derived from these chemicals, some anticonvulsants, sulfasalazine, sotalol, ibutylide, dofetilide, Dr. Lloyd is here, Dr. Hoskins is here, and Provencid for the use of gout. So many medications, countless medications, even some of the newer antiretroviral agents are derived from sulfa. And then an incident happened that led the FDA to actually have some authority. The FDA was formed, was signed into law by Teddy Roosevelt in 1906, but then in 1937 there was interest in having, instead of these pills or powder, there was interested in having a fluid, a liquid form of sulfa. So this company from Tennessee, Massengill Company, develops this elixir. Elixir implies that there's alcohol in the preparation. Okay, this is important for the lawsuits that happened later, and they put in basically antifreeze into the sulfonamide to dilute it, and diethylene glycol, and that's the chief pharmacist. He found that sulfonamide would dissolve in diethylene glycol. They did some early, sort of experimentation in flavor, appearance, and fragrance, but no safety testing at all. This was not required at U.S. law at that time, and there were hundreds of shipments all over the U.S., and many people died. At least 100 people died in all 15, more than 15 states, including here in Georgia in 1937, and then there was a very quick recall, and the Massengill company obviously was sued. And the pharmacist, Harold Watkins, commits suicide out of extreme remorse for what happened. And what's interesting is that the pharmaceutical company claimed that elixir implies alcohol and should not be given to children. Most of the people who died were children. And they argued that, well, children shouldn't have been getting elixir anyway. Obviously a very flawed argument, but an interesting little tidbit. And as a result of this, in 1938, the Food, Drug, and Cosmetic Act, to actually give the FDA authority over whether or not medications are approved. Before that time, the FDA had no authority. And this may have likely prevented the thalidomide disaster, the fact that FDA had authority. About thalidomide. So thalidomide, you may recall, was this medication that was given for morning sickness that caused horrific malformations, phocomelia in many parts of the world, particularly Europe. So the story goes as follows. The Grunenthal company files a 20-year patent in 1954, and then they market it as Gripex in Germany for upper respiratory infections. And then in Britain, it's marketed as Contergan for the treatment of morning sickness, even though there were no experimentations on safety, particularly in pregnant women. And then there's an epidemic. Thousands and thousands of children in Europe are born with these horrific malformations or stillborn. America, though, was mostly spared. 17 children were born in the U.S., were affected in the U.S. And that's largely as a result of the heroic efforts of Frances Kelly, who was a Canadian pharmacist working at the FDA at that time, and she was under intense pressure by her peers, by her superiors, by the pharmaceutical industry to let this drug go through. And she would not do it because she didn't think there was enough safety data to allow this medication to go through. And one of her allies was Dr. Helen Taussig of Johns Hopkins, who was one of the co-inventors of the Blalock-Taussig operation for blue babies. So here we have a situation where the FDA has been vindicated by this amazing feat. But what are the unintended consequences? The unintended consequences down the years and this is a very large topic that I'll only touch on today, is maybe this influenced how clinical trials were designed moving forward. Nobody wanted to risk teratogenicity in their medicine, so they purposefully excluded all women of childbearing age for decades in clinical trials. And that may have led to, for decades and decades, medicine was based on clinical trials on men and not women, maybe an unintended consequence of this episode in history. By the way, Dr. Kelsey was honored by JFK in 1962 for Distinguished Federal Civilian Service. Let's talk briefly about conflict of interest. And here's a story about pacemakers and conflict of interest and whether or not something like this could ever happen in this current era. So Dr. Walton Lillehei is one of the fathers of cardiac surgery. And he was at University of Minnesota. That's where he was born in Minnesota and the cities and in the Twin Cities, and went to medical school and trained there. And shortly after completing his surgical training, he was diagnosed with a parotid lymphosarcoma that required a quite large operation radiation that would actually shorten his career because of its effect on his vision a couple decades later. And in 1954, he started to do heart surgery with controlled cross circulation. That's hooking up the child to their parent as a heart pump. There was a heart pump that was in early experimental use, the IBM heart pump in New York, but the results were not particularly good. And even though he actually lost a parent during one of these operations, he kept going. And in 1955, he and other colleagues introduced the bubble oxygenator, and they were the first to successfully perform atrial septal defect closures and ventricular septal defect closures. The problem was, when you mess with the ventricular septum, you develop transient heart block a lot of the time. And transient heart block, even if it's for a little while, if you have no way to rescue this patient, can be a lethal event. They did have some early sort of pacemakers, but these were unwieldy, large things that you had to wheel from wall socket to wall socket, and not something that was practical beyond the hospital ward. So Dr. Lillehei was very interested in the work of Dr. Paul Zoll at the Beth Israel Hospital at Harvard in Boston. And Dr. Paul Zoll was very interested in treating heart block, and he had several quite interesting case series of treating patients for heart block. And one of the stories kind of reminds me of ECMO in a way. One of the stories is this patient with coronary disease who develops severe heart block, and here he is connected to an external pacer, and he's constantly being stimulated, being tortured. They're giving him some sedative, but he's hooked up to this machine, this pacemaker pacing him through his chest muscles, and the guy is being tortured for days and days and days. And Dr. Zoll was criticized for this. What are you doing? You're torturing this man. You're not allowing nature to take its course. So I think there are parallels to how we think about advanced life support during this current era. So having this information of Paul Zoll and external pacing, Lillehei has the idea of connecting leads in the operating room and having the patient being able to move around with some sort of battery-powered device. And so there's a power outage on Halloween 1957, and actually one of his heart block babies dies. So the next day, November 1st, 1957, he approaches this guy who works in the hospital. He repairs TVs. He does some medical work. He has this company with a funny name out of his garage, and here's this guy working in his garage, and here's his garage at around that point in time. And this guy was none other than the founder of Medtronic, Mr. Earl Bakken. And Earl looked at this very interesting problem, and he had the idea of having an electronic metronome placed inside this portable device. And here's a kid wearing this portable device for perioperative heart block. And then Dr. Bakken, or Mr. Bakken, he was an engineer, purchased the exclusive technology for the implantable device, where we could put something under the skin that the patient could go home with. And one of the very early funders of this fledgling company, Medtronic, was Dr. Lillehei. He was one of the major investors, and then later Lillehei would go on to develop heart valves with St. Jude. Medtronic would not be the first company to place a pacemaker. They were actually scooped by Siemens Alima. One day in 1958, this was performed and on Arne Larsen at the Karolinska Institute. So Arne Larsen was this man who had myocarditis and developed heart block from myocarditis. And his wife had to resuscitate him 20 times a day. He'd collapse on the floor, she'd pound his chest, and whether as a result or in spite of that, he would revive. And she was hearing about this work done at the Karolinska Institute with pacemakers. So she approached Dr. Rune Elmquist and Dr. Senning of the Senning operation and said, "Hey, you gotta help me with this. You know, we're not ready to do this yet. This is not something that we can do. It's still experimental." But because she was so persuasive, they actually relented and they did this. And here's this battery, mercury-powered battery with with metronome that may have been borrowed from the Medtronic guys, in this epoxy, and that you will see it's in the form of a kiwi shoe polish tin. That's how they formed them initially. And this was implanted. It failed just after a couple of hours, and then to put another one in, it was epicardial leads, and it was an abdominal device, and it failed again after a couple of days. But Mr. Larsen would have 26 pacemakers in his lifetime, and he would outlive both Dr. Elmquist and Dr. Senning, and he would die in 2001 of melanoma, not heart block. So it's interesting how there's a lot of potential conflicts of interest in these relationships between the doctors and industry, and whether or not something like this could ever happen in this day and age. So I have a couple of sort of final thoughts, and about modern medicine. And we live in an era where there's a pill for every ill, or is it a ill for every pill? Everything needs to be treated with a medicine, and we're very confident in how potent our medicines really are. And this is a quote from Voltaire. The art of medicine consists of amusing a patient while nature cures the disease. Another quote from Voltaire that I like is, "Doctors are men or men and women who prescribe medicines of which they know little, to cure diseases of which they know less, in human beings of whom they know nothing." I have a slightly more sanguine view of my blood is high. I have a slightly more sanguine view of medicine this day and time. We've come a long way, but we have a very long way to go. And what do I mean by that? We are strong believers in the pills that we push every day. Our medicines work, right? They work. How well do they work? Let's take a look at, this is from a slide I was, for another talk I was preparing, and this is how beneficial our heart failure therapies that we so strongly believe in really are. And what I want you to look at is the number needed to treat for a 12-month period of time. So we need to treat 77 heart failure patients for 1 year to save one life. 28 patients for beta blockers. 18 patients for aldosterone inhibitors. Resynchronization, 24. These are and if you look at statins, the numbers are in the hundreds. Statins are extremely potent medicines at lowering the LDL, but how potent are they really at saving? Certainly they save lives. But when we see a clinical trial that you got to enroll thousands and thousands of patients to eke out a few percentages of differences with a 20-30% relative risk reduction, what is the absolute risk reduction? How potent are our medicines really? Now, I don't want you to get the impression that I don't believe in modern medicine. That's not what I'm trying to say. What I'm trying to say is we need to have a honest appraisal of how far we've come, and we still got a lot of work to move forward in heart failure and coronary disease, and we should not rest on our laurels. So a couple questions to contemplate. These are questions, these are not answers, simply questions. Is the medical profession an underlying profession because nurses, doctors, we all take an oath, and that's where the word profess comes from? Is it an art or a science? I think we would all agree that it's a little bit of both. I think we're an art that uses science, and we have to realize where the art is and where the science is, and how we sometimes have a tendency of ignoring really good ideas when they come along, and we have a tendency of ignoring the unexplainable, the inconvenient, like hand washing, the unprofitable or the unpopular ideas that are not adopted by others. So, it's possible that we miss good ideas every day, that we overlook good ideas every day, and maybe having a little bit of insight could help us recognize a good idea when we see one. And then pride. We're very proud in our profession. We're very confident in what we're doing. Evidence-based medicine is infallible, and this is the right way to do things. And I think a modicum of uncertainty is something healthy. And then, certainly we need regulation. Do we need more regulation by the FDA, IRBs, or conflict of interest? Or do we need less? Or do we need smarter regulation that allows us to be more creative and to foster creativity and new crazy ideas? Other things are our funding mechanisms. Right now, our funding mechanisms reward the conformists among us. All the stories I showed you were mostly of renegades. So if we're tied down by an R01 or other grant and we really can't change direction, and the people reviewing our grants, we have to be judged in a certain way, and we have to be conformist in the way we do things, is that really the smartest way of fostering the science of the future? Again, I don't have answers. These are simply questions that I ask. And my take-home point, I hope you don't mind, is to keep an open mind, embrace uncertainty, and question the status quo, and be humble. History is a very harsh judge. And I'll end with the final quote. It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. By Mark Twain. Thank you. Y'all have any questions at all? Yes, sir.
Yeah, Maan, I'd just like to comment that I remember being a probably a fourth year medical student and being able to rotate through Piedmont and having Mark Silverman as a mentor, and he would suggest that we read a few articles, and he always had these cards, things that go over the exam, but he would also always ask us sort of what we thought about what was going on. And I think probably part of that was to test our knowledge, but the other part was that inquisitiveness of a student looking at things and saying, why are things a certain way? I also remember once I came on faculty here, and I had seen in consultation a few patients who he referred for transplantation, and after a while, I was talking to him one day, and he said, Andy, your notes are pretty good, but in the assessment, you really don't put enough of what you're thinking. Why did you think a certain way when you did something? You're listing a plan. He goes, but I as a consultant, it's very helpful for you to let others know, if you're an expert in an area, why you're thinking a certain way. So those are just a couple of reflections. I think your talk today is a very necessary type of talk. We had a grand rounds this year on A Tale of Two Brains and sort of the side of observation versus the side of knowledge. And I think your talk is just very helpful in And as I look at my son going through medical school, there's so much more information that he had to learn than what I had to learn. And people tend to think that the answer could be in the internet or what's there. But what's not, what a computer can't do is it can't tell you what is not known. And I think that your talk really touches on that. So thank you very much. It was excellent.
Thank you. Thank you very much.
I'll use the one that's already on. First of all, Maan, fantastic presentation, and especially how wonderful in memory of Mark Silverman. You know, being at Emory for many years, we've been very fortunate here that we really have seen and made the history of cardiology. I think those of you who are young need to recognize how wonderful of a place this is in cardiology. And I feel very fortunate, many of us, to have heroes like Mark Silverman, who really understood what it meant to be a faculty member, and the true gifts we give are the people we inspire to carry the torch on for the future. And Mark always taught me a lot, and he always checked back in to see how things were going, and motivated me at every step of my career. So, you know, Maan, I see you as somebody to continue to do that here at Emory.
That means a lot. Thank you. Thank you very much. Thank you.
The preceding program is copyrighted by Emory University.